Hello, this is Barbara Zarowitz. I'm faculty here at the University of Maryland School of Pharmacy. We'll get started in just a few minutes. However, we won't be able to start unless everyone who is not speaking mutes their phone. There's a lot of background noise right now. So please go ahead and do that until you have a question you're going to ask. And we'll get started in just a few minutes. Thank you so much. Well, good day, everyone. Happy spring. This is Barbara Zarowitz, as I mentioned earlier, and I think we'll begin today's office hours with a theme focusing in on antibiograms in long-term care facilities. That being said, really any question relating to any of the material in antimicrobial stewardship that you may be utilizing or having questions about in your facilities would be probably of great interest to others as well. I'm going to need to ask a couple of people in the background to mute your phones so that people who want to participate can. Thank you for muting. So with that being said, with me today for the faculty office hours are Drs. Christy Johnson, Dr. Kim Clays, Dr. Emily Heel, all of whom have spoken during our monthly webinar sessions and done an outstanding job of bringing forward further insights into the metrics as well as the use of antibiograms to assist facilities in achieving the now required phase 2 requirements for long-term care, but also the CDC goals of improving antimicrobial stewardship in long-term care. And I understand there were a couple of questions that came in on the website, and let's take a look at those. Here are some of the questions that came up while Dr. Johnson spoke, and here are the two new questions that we've just received. Let's start here. Some facilities use a surveillance program linked to the EMR for antimicrobial stewardship activities. What is your opinion about developing an antibiogram from the data retrieved from the surveillance program, especially when antimicrobial agents suppressed by the facility's microbiology department may not be reflected in the data, potentially causing some skewed results? And again, this question came up last month, but we wanted to hold it until Dr. Johnson could be available to take a crack at it as well. So with that, Christy, I think this is directed primarily at you.
Okay, thank you. Good afternoon, everyone. So we really shouldn't be using results of antibiotic data if the data is being suppressed or cascaded and is not coming through. So there's multiple ways to get that data. You can get that data from the antimicrobial susceptibility testing instrument and determine the percent susceptible from that. You can also, depending, as long as you know what the suppression rules are, some of the suppression rules you can actually determine how many isolates are susceptible. So for instance, if you have a suppression rule for, let's say, ceftazidime and E. coli. So if ceftazidime is susceptible and meropenem susceptible, you suppress the meropenem. So if you know that that is your rule, then you can figure out how many meropenem are susceptible, although they were suppressed. And if you're able to do that, then you could calculate the percent susceptible knowing your suppression rules. If you don't know by your suppression rule if the other antibiotic is susceptible or resistant, then you can't do it that way. If you can't come up with the data from the antimicrobial susceptibility testing instrument, then you shouldn't report the biased data.
Thank you. And I'm not sure if the person who initially addressed the question is on the phone, but I'm going to ask if that addresses it. But then secondly, if any of the rest of the faculty would like to respond as well. So for those of you on the telephone, which we really appreciate, if you're shy about speaking the question, I've just sent a little note to everyone via the chat box that you can feel free to type your question there, and I'll read it and we can direct it to the appropriate faculty as well. We're really here because we enjoy hearing what issues you have in the field, and our goals are to help you be as efficient as possible in implementing these programs. So don't be shy. Any other comments on the first item, the first question? So I'll move to the second question, which is how long can a resident be on contact isolation for MRSA of a wound after starting antibiotics? Sorry. And I guess that's kind of an open question for any of the faculty. Who wants to take that one?
This is Christy. I guess I can try and tackle it, even though I am not an infection control practitioner. I would think that this is based on what your infection control department protocols are at each facility, but I would assume that as long as the wound it still is draining pus, that you need to be on contact isolation. So I don't know if anyone else wants to answer the question.
Yeah, this is Richard Brooks at the Maryland Department of Health. So certainly as long as the wound is draining, it's reasonable to keep them on contact precautions. We also know that this has been studied in nursing facilities, and you know, even when people have been formally decolonized using approved decolonization procedures, it's well documented that the vast majority of people become recolonized with MRSA in a very short period of time. And so in general, we often don't recommend that people necessarily come off of contact precautions once they've been colonized with MRSA. But it is good for each facility to develop, you know, policies that specifically address these types of questions. And so would certainly refer you to your individual facilities policies to make sure that those are being adhered to.
I do have a question for you, because I thought that this question, it being a resident, would be in a long-term care facility. So if somebody is in a long-term care facility for a long time, when would you decide to take them off of isolation?
Yeah, so I was assuming they're in a long-term care facility.
Okay.
And this gets into an area that is very challenging for long-term care facilities and for those of us in the world of infection prevention, because we certainly recognize that people, you know, are often long-term residents of these types of facilities, and that being on you know, some type of contact precautions is often very challenging. We try to avoid the word isolation because we don't want to make it sound like these residents are literally isolated. They should not be isolated in terms of not being allowed to leave their rooms or participate in social activities and things like that. So certainly at the minimum, wounds should be covered, and clean clothes should be put on to cover even the covering of the wound. And then the resident themselves should be instructed to make sure that they're performing adequate and correct hand hygiene prior to leaving their rooms. But if all of those things are adhered to, then, you know, patients should be allowed to participate in other types of social activities and rehab and things like that at their facilities.
Dr. Brooks, thank you so much for, first of all, being on the line and sharing that information. As a result of, now that I know you're on, we may open to a broader array of questions that would affect facility requirements in general in the state of Maryland and have the expertise of the Department of Health. So thank you so much.
Sure, and then just to sort of do one other quick follow-up to that last question, which may have been part of what was being asked, is if someone is trying to decolonize a person who has had MRSA, let's say the wound is healed up and now you're just trying to decolonize them, that generally speaking requires having 2 consecutive negative swabs that are separated at least 72 hours in time, and that decolonization procedure and testing should not be done while somebody is still on antibiotics and should not be undertaken until they've been off of antibiotics completely for at least 48 hours.
Great information. Thank you. All right, it's over to the audience. Once again, feel free to type your questions or ask them. Edna, maybe we can look at the questions that have come in previously on the next slide. Or the previous slide. Yeah, sorry. I show these primarily to see if there are any follow-up questions this provokes or if any further information is desired from participants.
Come on.
If not, yes, please go ahead.
It's muted.
I'm working on the, when it says the top.
Is someone trying to ask a question? I hear a voice. No? Okay. Well then, I have a little exercise for us, and again, we'll take questions at any time, but Edna, if you'd like to go to the last slide. I thought I'd put together a little situation that we can say, let's apply some of these metrics that Dr. Kim and others have shared with us in previous sessions, both at the summit and during the webinars. And it's a little busy, so we're going to get the opportunity to walk through it. But let's presume this is antibiotic stewardship metrics for 1 month in a facility in just their short stay residence. And as you know, it's really great to separate out these metrics in short stay versus long stay, because sometimes the causes of the infection and the utilization of antibiotics and other medications differs quite substantially in patients who are in their rehab, if you will, or post-acute care versus those that are in there over a prolonged period of time. So in this situation, we're looking only at short stay. And so the kind of information that has been reviewed that might be available or could be part of a metric other than the corporation name and the facility name would be the number of residents in the facility. This would be a function of filled beds, the number who are receiving antibiotics, the percent that are receiving antibiotics, and we'll go through these in a minute. The number admitted to the facility over that last month, and of those, how many received antibiotics. So here we're going to get at the notion of, did they come in on antibiotics, or was the antibiotic use primarily that of residents who have been in the facility longer than a month and therefore acquire a new infection, probably not related to their acute care stay or whatever put them in the facility in the first place. Percent of new admissions receiving antibiotics, number of new antibiotic starts, so these are the ones actually started in the facility. And then we get into some of the more interesting metrics as outlined in the CDC Appendix B document, the rate of new starts per 1,000 days, the sum of antibiotic days, otherwise termed affectionately the DOT or the DOT, the antibiotic DOT, which is again just a function of the sum of the days, and the utilization. And then lastly, the AUR, which Kim spoke of quite nicely, or the antibiotic utilization rate. So if we look at the examples, we can see that this corporation is showing data from 3 facilities that have a range of filled beds. You can see 100, 120, and 100. You can see if we look only at facility 1, that 20 of their 100 residents received antibiotics, which is 20%. 12 of their 100 were admitted to the facility over the course of the month. 10 were admitted on antibiotics. So the rest of the antibiotic utilization was obviously in residents already in the facility, not those newly admitted on antibiotics, giving us a percent of new admissions receiving antibiotics of 83%, 10 divided by 12 times 100. Then the rate of new starts, so that's just the previous column of 10 normalized and divided out, and that's a 3.3 per 1,000 resident days. The 280 days in total of all the residents who received antibiotics over the course of the month, that's the sum of the antibiotic days at the DOT. And then lastly, I'll go right to the last column, antibiotic utilization rate of 31.1 per 1,000 resident days. Now, how does that compare for the other 2 facilities? As you can see, there's quite a bit of variation. And it makes it interesting because if you take a look at it, facility number 2 may have the greatest opportunity to improve antibiotic utilization. And why would I say that? So as we look across, 70% of their residents are receiving antibiotics. So that's a very large number, certainly as large as has been reported in the literature. But what's interesting, 50 residents admitted to the facility, only 10 of them came into the facility on antibiotics, so 20%, which really means that the vast majority of these antibiotics are being started in the facility. And it follows quite nicely as you look across, because you see 326 days of antibiotic therapy and an antibiotic utilization rate of over 100. So it seems like there's something going on in that facility that might be leading to a higher infection rate, not only who is coming into the facility from the hospital. Whereas in facility number 1, as you can see, there are 20 receiving antibiotics for a 20% rate, and most of the new admits come in already on the antibiotics, suggesting they're coming from the acute care facility already being treated, and they're just completing a course of antibiotics in the facility. And despite that, their antibiotic days of therapy are reasonable, and the utilization rate, 31 per 1,000 resident days, is reasonable. So there's a very different pattern between 1 and 2. And then if we go back to the slide, Edner, I'm sorry. Thank you. Facility 3 has essentially 19% of the residents, of the 100 residents, receiving antibiotics. 100% of the new admissions come in on antibiotics, and only 1 new antibiotic was started during the admission for the remaining residents. And they have a very low antibiotic utilization rate. So if you compare these 3 facilities in that nature, you can begin to detect where the opportunity might exist to develop strategies to improve antibiotic utilization. So for example, in facility 2, as we've already said, with a pretty high antibiotic utilization, quite a few come from the hospital on the antibiotics, but in addition, there's a very high increased use of antibiotics started after the resident is admitted to the facility. So I would be there with my quality assurance hat on, looking for, well, what are the organisms? Is there a problem with hand washing? Is there a problem with, as we've discussed previously, contact isolation not being followed for things such as MRSA or C. diff? What are the other potential reasons that we could have high antibiotic utilization? Are prescribers starting antibiotics for urinary tract infections, perhaps for asymptomatic bacteriuria? I mean, these are the kinds of questions you could begin to ask. Versus in facility 1 and 3, where the vast majority of the starts are happening in the hospital, it might be an opportunity to partner and collaborate with the individuals, the professional staff there in the hospital, to make some determination and understanding about what's going on in the hospital, what are these infections, are they all C. diff coming to us from the hospital? That would speak to an opportunity for the hospital to look at their program as well. So it might involve a slightly different tactic. And so let me pause there, and then we'll ask the third question. Is that making sense to people, the way that you can perhaps look at these data and begin to evaluate opportunities? Any questions as I'm going through this? I'll go on then to look at how would your recommendations change if these data, instead of representing 3 facilities, represented, let's say, January, February, and March in one facility. So all one facility 3 months in a row. So the admissions vary a little bit. The rates, of course, are what we've already seen. What would you be asking? Well, I personally would ask, what happened in February? Did we suddenly have an influenza outbreak? Did we have MRSA that wasn't controlled within the facility? Again, this is just the tip of the iceberg. But again, it represents the opportunity to be inquisitive and allow these data to provoke investigation into your program and how you might be able to interpret and then subsequently develop strategies for improvement. So once again, this is all contrived information, just available for us to have an opportunity to ask. So let me go back and say Dr. Johnson is still available on the phone. Are there other questions for her related to antibiograms or the laboratory role as it relates to the development of these tools and initiatives for antimicrobial stewardship?
Hi, Barbara. This is Nicole Brandt. I first wanted to say thank you for the metrics per month. I know that was a question that came in over the past. I don't have any specific questions, but I know we have a couple of different infection preventionists from different health systems. I'd love to hear their perspective on how this data is presented and how they're tracking this over time. I think this, visual gives us a good perspective of topics we've talked about, but I'd love to hear from others some of their challenges, but also some of their strengths of what they've been able to be successful with. So I don't know if others on the line might want to chime in. I know we have some colleagues from Stella Maris and others, but just thought I'd open it up for a little bit of discussion too.
Perfect, thank you.
Mm-hmm. I don't want to call out anybody in particular, but maybe Jackie, if you could chime in from Stella Maris, or there's no right or wrong, but we're just trying to learn from each other here in these faculty hours and forums. And we don't want this to feel like a lecture, but more of a conversation.
Can you hear me?
We can hear you, Jackie. Thank you for chiming in.
Okay. So in regards to antibiotic stewardship and us using our antibiogram, I know, so I've been at Stella for a total of a month. So
So you're really new at this, so you're learning as well.
So I've been infection prevention for the last 10 years in acute care. So it's
Okay.
something new to me with long-term care, and I'm finding it's extremely different for everyone.
Okay.
We're blessed in the fact that Mercy does all of our labs here, and they have the tools in order to give us an antibiogram. And Stella has had a very, we actually lost our infection preventionist to Mercy. So Bernie Miller actually went to Mercy, but for the past probably 14 years since she's been here, she's been very active. So I know we've been using an antibiogram, and I do believe it's been pretty helpful in regards to tailoring our antibiotic use. I know that since she's left, so we were without an infection preventionist from, I guess, late October, beginning of November last year until they hired me in February. So I think it kind of went.
We're losing, Jackie, I'm sorry to interrupt, it's Barbara. We're losing your voice a little bit. Can you pick up your phone?
I'm actually speaking through the laptop.
Okay.
So
Go ahead.
did this get better at all?
It got better. Thank you.
Okay, so I opened it up. It's the first time I've spoken via this laptop, so I'm not sure how the microphone was going to pick up or if it was going to do it at all. But yeah, so we've been very blessed, but since Bernie left and I took over, there were a number of months that lapsed. So during that period of time, I guess, antibiotic stewardship meeting didn't meet. We also, our infection control committee didn't meet, but I know the antibiogram, I believe it has been helpful in the past with antibiotics. We do have a little bit of challenges with some of our physicians. So we have a number of nurse practitioners that are here, and our medical director, and more facility-based physicians, if you will, and it's so much easier to get them to buy into utilizing the antibiogram and any kind of algorithms that we come up with in regards to antibiotic use. But we do have a few docs that say, like, we have Kaiser residents, and the Kaiser docs come in, and then if it's after hours, then a different Kaiser physician kind of is on call, and it's really hard to get those random on-call physicians from different places to kind of buy into the use of the antibiogram and any kind of algorithms that we have in place. So that's our big challenge now is getting out to all the physicians, if you will, and the ones that aren't normally here. And I think that's kind of a commonality that they also see in acute care too. So in the acute care side, like the hospitalist that's employed by the hospital, it's extremely easy to get them to, well, it's not extremely easy, but it's a lot more easy to get them to buy into an initiative that the hospital's putting forward, like antibiotic stewardship, versus the physician that may or may not be there for this one patient, or when his other patient comes along.
Well, Jackie, I think you hit at quite a few things, so thank you for letting us shout out to you to give some perspective. But it sounds like one, as you said, a strength is you're working with a health system, Mercy, who helps to provide the antibiogram. But then it sounds like one of the challenges is, how to distribute that antibiogram to people who are not strongly affiliated with your system, which is kind of a problem I think many of us on this call can resonate with. Well, we've got, actually, I think we've got Tim and we've got Dr. Johnson on the call. Is there any considerations as we're using and clarify, correct me if I'm wrong, in terms of if we're using antibiograms that are based from, is it based from the hospital system or is it based from your long-term care system? Jackie? I don't know if she heard me.
I'm so sorry, I was on mute.
That's okay, no. But I guess my question is, because I know we talked during the antibiogram section with Tim from the state, some of the challenges we have with having enough isolates and testing to have a good our own antibiogram. Is your antibiogram based just on the long-term care side, or is it coming from the larger health system?
So it is actually ours specifically. And I know this, I haven't actually sat down and reviewed the last one that I haven't reviewed last year's. We just actually received last year's from Mercy. But I know that they've used it in the past. So I know last year's is a little challenging because Mercy actually went from, I believe, Meditech to Epic. So we have one from the first half of the year and then one from the last half of the year. And what I want to try to do is look at those, and if there's any way that I can basically merge them, because I know they're just kind of numbers and isolates, but that's one of the things that I wanted to do going forward. And it's been incredibly helpful that Mercy is able to do it for us, period, as well as do our labs. Because in just regards to case finding and looking up surveillance infections, case finding is actually difficult, but we actually have access to Epic, so we can go into Epic and look at all the labs for our residents, and that's a little bit helpful. Also, the clinical pharmacy, we have Remedy that provides us with detailed reports of our antibiotics usage, which we can then utilize that report and look at our fluoroquinolone usage as well, and to try to see if all of our infections that we've prescribed antibiotics for, to see if they kind of meet any of the surveillance definitions.
Okay, wow, that's a lot of data sources. I'm not sure if Dr. Johnson, any thoughts? Yeah,
I did actually. I wanted to talk a little bit about your comment about merging the two. So that can be easily done, and it is explained in the M39 if you happen to have a copy of that. But if not, it's a little bit of work where you would have to go through, you should have the N for each organism and antibiotic, and figure out what the N is for susceptible and the N for resistant, and then add the 2 years together of how many is susceptible, and then you know what your denominator is, and then you can determine the percent susceptible adding the two time frames together. Did that make sense?
It does actually make sense. So what is the N39? I think
so the M39 is a document that is that you can buy from the clinical CLSI, which is the Clinical Laboratory Standards Institute, and it is a very large document telling you how to make an antibiogram. And a new one's about to come out, which I spoke about a little bit on my webinar, and there's going to be a whole section just talking about long-term care. But within that document, it tells you how to take data from 2 time periods and add it together if you don't already have the data. So Mercy has the data is what I'm understanding, and you're just trying to take the percent susceptible from your antibiogram and merge to 2 different time frames together. And so it does talk about that in there, but that's exactly what I said, where you just figure out, because the N is the number of organisms that they use to determine the percent susceptible. And from that, the percentage, you can figure out right? So if it's an E. coli and it's 80% susceptible and you have 100 isolates, you know that 80 of them are susceptible and 20 of them are resistant. And then you go to the next year or the next time frame and do the same thing and then add the numbers together to get the percentages.
Thank you so much, Dr. Johnson. And, you know, Jackie, for your reference, Dr. Johnson's information was on her slides, her email contact as well. So sorry, I'm kind of volunteering you, Christy, if Jackie needs
That's
to
okay.
clarify. As she goes through the exercise, I know part of what we want to do is support all of you. So there, I'm volunteering Dr. Johnson.
Thank you so much for volunteering her, and thank you for being
Yeah,
available.
Yeah, no, Jackie, thanks for chiming in. I know that you've been present with some of our other programs, and we want to just open up the conversation because there's, I'm sure, others that are probably thinking, oh, I had no idea what M39 was, and how do I look at these labs through the years? So I think that's great. Are there other questions? Because we're all learning from each other here, or other comments?
So this is Fatima Sheikh. I have a question about the antibiogram. The example that was shared was for short stay patients with less than 100 days in the facility. So we actually get a cumulative report from our lab services, and we partner with Good Sam Lab. We get a quarterly data in an antibiogram, but that's a cumulative data for both short-term and long-term patients. So the question is that should we be requesting separate data for the short-stay residents? Or is it okay for us to tease through the data once we get the detailed report from our pharmacy as to what antibiotics we have used? But that's certainly a different data as compared to antibiogram.
So this is Barbara, Dr. Sheikh. Thank you for your question. You know, I know that some pharmacy providers divide it. For example, Omnicare does. I don't know if Remedy does divide it between short and long stay when they're presenting the monthly antibiotic reports. But you know, if you get an aggregated report, I think it's still helpful. I just think you can't as easily develop a strategy if you don't know for sure what the derivation of the antibiotic utilization is. I don't know. I mean, Dr. Johnson, would you add to that?
When it comes to making the antibiogram, I mean, those patient populations seem to be different. And so you can make an enhanced antibiogram where you just focus. So we do this here at my institution. So for instance, we have antibiograms that just focus on patients in the ICU or patients in the ED. And those antibiograms are different from each other. And so having that separate data could be useful, but you're saying that they're sending you all that data, or they're just making one antibiogram with both short and long stay? And is there a way, like for us, we use location to determine where the patients are located, tells us that they're in the ED or tells us they're in the ICU. And I don't know if that's how it works in your institution. So by patient location, you would know if they're a short or a long-term stay, because it gets pretty complicated if you have to figure out their length of stay.
So to answer your question for the antibiograms, it's cumulative data because we have not a very big population in each facility. So they don't divide it into long-term and short-term patients. And I wonder if it were to be separated into short-term and long-term, whether that's going to decrease the number of cultures that can be reported in an antibiogram. So that's going to decrease the number.
Yeah, it does. But what we do at our facility is then in some of the ICUs, we don't have more than 30 isolates in a 1-year time frame. So we'll actually look at data for 2 years or 3 years. And if we look at like a 2-year results, then we'll get more than the 30. And so we'll have a higher number, and we'll use that data to present on the antibiogram.
Great, thank you so much for the suggestion. I will discuss it with my lab to see if we could divide it up. That would be very beneficial. As you said, because the populations are so different, the risk factors are very different too.
Yeah, thank you, Dr. Sheikh, for that question, and Dr. Johnson for clarification. So let me just recap that. So what I'm hearing you state is it would be best to break out the short versus the long stay residents based on location. To overcome the challenge of number of isolates is extending the duration of time that we collect that data. Am I capturing that well, Dr. Johnson?
Yes.
Okay, great. Other questions or thoughts with respect to things that you might be working with? I know there was some other colleagues from some other health systems, not to just put Jackie on the spot, but I think there's a couple other health systems represented on the call. Any thoughts from your health systems of things that are working or not working so well? I think Barry's one of our pharmacy colleagues. Barry, do you have any thoughts from your experiences?
No, not really at this point. No, I'm sorry.
No, that's okay. I know you're in the ambulatory care setting and across different care settings. So I know one of the challenges with navigating all the different types of data. So again, I know we heard about the different EHR systems and then the microbiology systems. And sometimes there's not seamless connectivity with all that information.
No, there's not, but we're sort of lucky because in our area, most everybody has Epic. So you can at least use Care Everywhere or at least get on, and it's a pretty close-knit community here, so you can always call a pharmacist from one of the other sites or facilities and ask for some further information, and they're usually pretty good about giving it to you. So it's a little bit different here, I think.
Great. Thank you. Thanks for sharing that. Are there any other? Go ahead, please.
This is Richard Brooks. I was just curious. There was a previous slide that was shown with previous questions from the last webinar.
I didn't know. Back to that one.
Did the question about outpatient antibiograms ever get answered for somebody? Because if not, we can certainly address that.
Let's go to that one.
Asking about a community outpatient antibiogram and whether anyone had suggestions for what constitutes an outpatient site, for example, ERs, physician offices, home health agencies.
We talked about it on the webinar, but I think it would be great if you want to go over it again.
Okay, yeah. Sure. I mean, I can weigh in, and I'm sure, Dr. Johnson, you have your own perspectives too, but I mean, this to me sort of also, so first of all, just getting access to those data is very challenging. The person who asked the question very perceptively asked whether the laboratories would even collect the place or location of the specimen that was received. And at least in my experience here at the health department, that data is often not included. And so knowing sort of what setting it was where the specimen was collected is often not known. So that's one big challenge to doing that. And then Dr. Johnson talked about, trying to create more enhanced antibiograms where you're looking at sort of more specific patient populations. I would argue, that somebody coming into the emergency and having a culture collected probably is a different kind of person than somebody who might be receiving home health care and having a culture collected, and that's an even different population from people who might just be presenting to their outpatient primary care providers and having a specimen collected. So, trying to make sure that the population that the antibiogram is being created for is as homogeneous as possible would certainly be important. But again, I think before we even get to that point, I think it's really hard to think about ways to get these data in order to even be able to do that in the first place. So certainly recognize that it's a need, but it's a very challenging one, and I don't have great answers about how to do that right now. Dr. Johnson, I don't know if your system, has a better way of tracking those data in order to sort of enable that, maybe for something like the emergency room, but I don't know about that.
Yeah, so with our system, I actually can see all of that. So in my laboratory, we perform microbiology for 6 hospitals, and we also have outpatient clinics. So the way that Epic is set up, the location comes across to us. So we can see that if it's from a clinic from in the community, or we can see that it's our ED, or we can see that it's our ICU. And so we have all that data, and I'll tell you that I make my antibiogram from Epic data. So I don't make it from the antibiotic susceptibility testing instrument. And so those instruments might not have that data. So it all really depends on whoever's creating the antibiogram, where they're getting their data from. And I guess how it's set up. So our system's set up, I can see that it's from another hospital or from a physician's office.
Well, thank you both for that. That was really helpful. I think there's so much more to work at and learn from. So thank you for that, Dr. Brooks and Dr. Johnson. Other thoughts from others that are on the call in terms of any questions that were asked previously that you would like some additional information on, or as that discussion occurred, any clarifying questions?
So this is Fatma Sheikh again. So I don't have a question, but I wanted to share an observation.
Please.
So I go to different facilities that are located in different parts of Maryland. So in Baltimore facilities, I noticed that for our E. coli that are most common culprits for UTI, there was much more resistant to Bactrim. But in other parts of Maryland, closer to DC, actually there was still some preserved sensitivity to Bactrim. Around 80% of E. coli were still sensitive. And again, that's a limited data based on the isolates that we had in one of the facility over there. So, but it was just a very, very interesting observation that I wanted to actually share with the group.
That's a really good point. Go ahead, Dr. Johnson.
I'm sorry. It seems to me that might have to do with the practices of the facilities. So what is their main go-to? Do you think that's why you're seeing that?
So I actually would ask you if you could expand a little bit on that. What kind of process?
So in Baltimore, do they use more Bactrim versus closer to DC? Oh. It might not be the drug of choice that they use, and they might use a lot less Bactrim.
I think that may be a possibility. I haven't teased out the causes for that difference. So it may be also that this population in Baltimore, they are probably sicker and they go to the hospital more often.
Yeah, so Bactrim resistance, we see that a lot. Also with ESBL resistance, because it comes from the same plasmid. So I don't know if in Baltimore the rates of ESBLs are higher, which are extended spectrum beta lactamases. Because if that's also higher, you would see that too. So your resistance to like ceftriaxone or a 3rd generation, if that's also, your resistance rate is also higher and correlates with the Bactrim, it could just be, more resistance.
So that's a great point. I'm gonna look back at my data to see if there's a correlation with the ESBL. As you said, there is a great possibility that the antibiotic resistance in Baltimore area is because of that. So thank you for sharing that. I will certainly look into that a little bit more.
Sure.
So let me just recap that again, because I think those are other really great learning points. So what I'm hearing stated is, Dr. Sheikh, you've noticed these observations of increasing Bactrim resistance, trying to understand the factors or the driving factors that might be causing that resistance. And Dr. Johnson, not just the use patterns, but also if there's other resistance patterns that we could pick up from our laboratory and our antibiograms might help us get additional insight. Is that correct in what I'm stating?
Yes.
Okay. Awesome. Well, I have to say I've learned quite a few things today on this call from all of you again. Are there other observations that you're wondering while we have statewide experts and system experts on the call? Any other closing comments, Dr. Johnson, Dr. Brooks? I think Dr. Clays is also on, just regarding the webinars and the content.
I just wanted to say that it was stated earlier that my contact information is included in the slides. So if you have any questions after this, you can send me an email.
Greatly appreciate that. Very helpful. Tim or Richard, anything else from the state perspective?
I don't think so, not that I think of. We're obviously also always available for questions, so
great.
Reach out.
Wonderful. We'll just put another just reminder in. If you haven't registered already, we'll be having another program in April. And Dr. Heil will be talking about allergies to some of the antibiotics. And and then we'll continue to do the faculty office hours. But as was mentioned by many of the faculty on this call, you have our contact information. Feel free to reach out to us. And we recorded this, so hopefully for others who weren't able to listen in, we'll be sharing this on our website. So at this time, I just want to thank you all for your time. Again, want to thank our faculty for participating, for Barbara for leading this, and look forward to talking more in the future. Have a great afternoon.